facilitate a Q&A at the end of the session. So I'd like to welcome our first speaker, who really requires no introduction, but Kylie Sproston, CEO of Bellberry, and thank Kylie for her time and for her presentation. Over to you, Kylie.
Thank you, Joe. Thank you for the invitation, and thanks to the audience for taking the time today. We are going to try and prioritise as much time for questions and discussion at the end. So I have got just a few slides just to provide some outline on, I guess, the Bellberry view on where we are with studies, COVID, and ethics matters. In sharing these comments, we really have aimed to provide some really practical comments and tips and tricks. They're clearly not aimed to be either universal or necessarily complete, and it's important to say at the outset that all of these considerations should be made on a case-by-case basis, both in terms of study and in terms of local context, and I'll talk about that quite a bit as we go through. If you could skip through to the next slide, Joe. So really, I'm going to focus comments on three areas. First of all, prioritisation, and secondly, then some thoughts on pragmatic approaches, and then I'm going to leave you with some tips and tricks. And as I say, really, we've tried to be very pragmatic in terms of site level considerations. Next slide. So from a prioritisation point of view, I think the first thing to say really is, and I'm sure there's no debate about this, really, we should be and all will be focused on prioritising the safety and welfare of research participants in these conversations. But if we go to the next slide, I think it's actually important to really kind of progress beyond that, because there are some nuances that we think it's important to recognise. Some of these are assumptions. So really, the first assumption to make, I think, is that we're expecting that sites will approach some of these topics with flexibility, adaptiveness, and responsiveness. We're seeing, or we have certainly seen over the last 6 to 8 weeks, a situation that has evolved rapidly. I'm sure we're probably all reflecting that certainly in many places around the country, we're in a better position sooner than we might have expected. And so equally, hopefully going forward, we might well need to actually kind of reverse some of our responses equally quickly. I'm speaking as an optimist, I guess. It's important to remember local context and the need for prioritisation in both your study considerations, but also in terms of your local contribution to national suppression or elimination objectives. And in terms of we're going to talk a lot about risks, I think. For studies and sites, it's really important, I think, to balance risks. So consider the risk of continuation versus the risks associated with discontinuation of studies. And obviously, there's lots of different levels at which we could have that discussion about both continuation and discontinuation. But it's important, I think, for people to actually articulate what some of those risks are so that you can actually start to measure and mitigate those. When we talk about the practical tips, really, we're going to be focused on exposure reduction as a goal. And that may well be kind of separate to zero as a goal, because these are complex kind of balances of risks and considerations on kind of both sides of the balance sheet. If we go on to the next slide, in terms of ethics and governance processes, really, I mean, I'm speaking directly on behalf of Bellberry HRECs, but I'm sure, speaking more broadly, if I think about conversations with our jurisdictional colleagues and other hospital colleagues, I think you'll probably find we're all saying very similar comments. HREC and research officers are approaching this situation with flexibility and responsiveness as much as we're expecting that from sites. So whether we're talking about extensions, deadlines, renewal dates, reporting dates, I'm sure we will all approach these things with flexibility and responsiveness. Compliance is important. So I think, you know, at the end of this, we're expecting everybody to have worked back to compliance, but we are recognizing that we are in a rapidly evolving situation. We have been in a rapidly evolving situation. And so there may well be times where sites are having to make decisions and then complete processes, documentation processes and approval processes later. And we will work together on that. Very much in a team approach. So whether that's between studies and sites, across sites, or indeed across jurisdictions, I think we're all in this together. And certainly in terms of Bellberry, we have made available batch processing. So whether that's by sponsor submission, or whether it's by study submission, or indeed whether it's by site submission, we have enabled batch processing requests to really try and assist sites with reducing their workload at a time when they've got a lot on their plate. And I'm happy to talk about that later if there are specific questions. If I can go to the next slide. In terms of pragmatic approaches, really, we'd encourage sites to, you know, start off with practical details of what they're looking at, and these considerations will be on a case-by-case basis. So whether you're based at a site, or indeed whether you're in a CRO or a sponsor, you know, you should be considering the specific requirements that relate to the studies that are in front of you. You know, think about your participant cohorts and patient demographics that you're talking about and their particular needs. Equally, you know, focus in on the needs of your study, your site, or your sponsor requirements, and those will be different from one to another. It is important to undertake local contextualization, and I think increasingly this is actually going to be about reflecting on the global context as well as state to state variations. You know, I think we're all kind of scanning around the world for things like regulatory changes, but it is important to recognize that certainly globally, jurisdictions are in very, very different situations. So when we look at regulations, it is going to be important to check in Australia. I mean, you know, pleasingly, as we find ourselves in a situation in Australia where the curve is coming down and the response has been, it gives cause for optimism at this point. You know, there may well be regulatory decisions in other international jurisdictions that are not sensible for the Australian jurisdiction. And equally, of course, we are seeing state by state variations. So it is important to take those into account when you're making your plans, both in terms of either kind of escalating contingencies or de-escalating contingencies. And then really the final point, we would encourage sites to have contingencies in place and be ready for change. And pleasingly, we are now talking about both de-escalation as well as escalation in some jurisdictions. On the next slide, I'm going to talk about tips, and I'll talk a bit more about what those contingency plans might look like. In terms of tips, we'd encourage study staff to be thinking about risk assessments. So, you know, in your study portfolio, you know, you should be considering, do you have any studies which are inappropriate for continuation at this time? You should be considering the local COVID context. So what are the numbers in your local community and in your local state? What is the need of your clinic or your health system to prioritise or otherwise? Consider the risks of discontinuation versus continuation in your particular participant cohort. If you can, start thinking about physical configurations. You know, we've seen lots of imaginative thinking by sites around separation of activities, you know, using separation of workflows to enable reduction in numbers, which is all about reducing exposure risk. We've seen lots of sites making really sensible separations of their workforce, you know, ensuring that all activities have backup personnel and that those personnel are entirely separated chronologically. You know, think about your sanitizing regime, thinking about your PPE, you know, what's required and availability. And once again, that's going to be really important to factor in on a in addition to the local context. Think about your study requirements. So things like visits, monitoring, intervention, other study requirements, pathology, and think about whether there are different approaches you might be able to use. Of course, we're all getting very au fait with using technology. Now is the time to really use this as an opportunity to think about some of the remote methods and technologies available, whether that's something pretty straightforward like e-signatures, or something that you might not yet have experience of in terms of telehealth systems or e-consent. And reach out. There's lots of resources available to help you if that is a first time that you're approaching those, whether that's through ARCs or your local health department, or Praxis, or there's lots of resources available to assist. Liaise with local health colleagues. So we know that a lot of sites are working kind of hand in hand with either their local hospital or their local health department. And that's in terms of both understanding what their health department needs from them, but also, knowing when it's necessary to escalate and when it's necessary to de-escalate. We know there are, very significant differences across the country. There are some communities that have been asked to deprioritize anything that is not COVID related, but realistically there are other sites within Australia that are not in that situation, and so we shouldn't be taking a one size fits all approach with this. What we would encourage all sites to do is develop contingency plans. So if your local community isn't at this time in a situation where you need to deploy contingency plans, it's probably still good practice to have those in place. And when we say contingency plans, really develop your policy, develop your SOPs, train your staff, do whatever is required to enable you to deploy those plans as and when it's necessary, and equally start thinking about how you would exit from those plans where appropriate. And that was it for our practical tips and trips, and I'll look forward to taking questions at the end. Thanks.
Thank you, Kylie.
We can hear you, Shannon. Go ahead.
Yeah, so, thank you. I apologise for dropping out previously. Technology doesn't always work with us. So that was very useful tips there, Kylie. I now would like to hear from Tam Ewan, who's from Melbourne, and he will be talking to us next. Thanks, Tam.
Thanks, Shani. And if you go to the next slide. So before I begin, I just want to acknowledge the traditional custodian of the land that we meet today, and pay my respect to the elders past, present, and welcome any of the Aboriginal and Torres Strait Islander people who might be online with us here. So I've got 3 slides really focusing on in terms of plan for managing clinical trials in this COVID-19 disruption, and provide you with some of the updates and link on what's happening around the world, followed by really sort of issues to consider in terms of ongoing management of current trials, and then some of the issues to consider with new trials. So we can go to the next slide. And this is just to say that we've launched or released our plan for managing clinical trials in this setting of disruption in mid-March, and a lot of other hospitals would have similar document on their website. And as you can see there, certainly the a number of groups again providing statement to support in terms of I guess guidance for on clinical trials for institution, HREC researchers and sponsor. And I should also emphasize that in addition to the safety of our trial participant, it's also our staff as well. So staff, the safety of our staff is also their priority in all the actions and decisions regarding trials activities. Now, the the Department of Health, this released the CT-PRG statement on clinical trials. I think that was last Friday on 17th of April. If you haven't had a chance, make sure you visit that just to make sure that it's you across all of the information. In the UK, MHRA released a similar sort of guidance document on managing clinical trials during this coronavirus pandemic. So that was updated on the 9th of April. FDA has their guidance updated, I think, last week on the 16th of April. Again, these will be, the key thing with this is that these guidance, you just want to make sure that you're across these guidance and are not, I guess, in direct conflict. And if in doubt, just refer to your local hospital. If it's multi-site, refer to the lead HREC for advice. So if we go to the next slide, looking at consideration for ongoing management of current trials. And so these are some of the,
Just
I
bear
actually
with
got
me
a
for a
hyperlink
second.
to that.
Yeah, no, I see that now.
Just go next.
Yep.
Yeah,
Got that.
perfect. Yep. Yeah. So these are some of the things that my team have been working on, and everyone's sort of working from them now. Is that the amendments in relation to, for example, protocol, to the consent form, right through to notifications, varying variation of method of supply of IP, for example, or modification to pathology collection, some of the reporting as well, and some of the things that we've seen is, for example, IPs, whether it's generic versus label, and on that, communication is so important because, if the participant used to seeing, their label product in a certain way, now all of a sudden you have the generic, you have to actually provide clear communication, timely communication to participant to avoid any sort of undue burden and anxiety, for the participant. Pathology collection, some of the things that we see, because with the local hospital pathology, it might be deferred to or relocate to a local service provider, for example. So that's something to to keep in mind as well. And again, if in doubt, just get in touch with your local hospital HREC for advice. And right to looking at, for example, to conduct remote patient visits or assessment, and we get this quite regularly as well, where it's all about the safety, and again, couldn't stress enough on the safety of our staff as well. So if the coordinator previously wasn't visiting, doing home assessment and so on and so forth, then it needs to be built in with I guess, their job description and all the safety mechanism in place to ensure safety for the staff. I guess the other one is looking at if patient participation in clinical trial when they become infected with COVID-19, and so there's the guidance, the statement from the CT PRG outline that quite clearly. Obviously, you need to treat the COVID-19 aspects first, and then the other big one is probably on remote monitoring, and so we can sort of certainly discuss in details over the Q&A. Conscious I got one more slide, but just one point about remote monitoring is that it's whichever approach you take, you need to be mindful of the participants but also the staff, not only on their time, but also the resource in terms of transition into a new environment for remote monitoring, for example. So that's something to keep in mind. Let's go to the final slide. Thanks, Joe. So for new trials, and again, we were one of the first group confirming with NHMRC to make sure that we can conduct our HREC meeting online, and the procedure needs to be clear, and in particular with expedited review for COVID-19 related study. And so again, it's on mostly in the hospital HREC website in terms of outlining, sort of the procedures. With us at St Vincent's, we decided to provide extra support for investigator-initiated study on COVID-19 related study, and simple things like waiving the fee and provide extra support, because I mean, obviously, to reduce the burdens on our research group and for PIs and coordinators as well. Again, new patient recruitment, in particular to COVID-19, it needs to be really in careful consideration with their structure within the hospital to again protect the patient safety. And the last point is about trials involve healthcare professionals. And again, you would have seen a number of trials looking at different type of vaccination for healthcare professional. Risks need to be looked at thoroughly, and making sure that everything is done at the right sort of level to ensure safety. Again, couldn't stress enough, not only for patient, but for our healthcare professional who are sort of front line as well. I think I should stop there, and really looking forward to the Q&A session. So thank you again.
Great. Thanks very much, Tam. Thanks for your time. That was Dr. Tam Nguyen, who's the Deputy Director of Research down at St Vincent's in Melbourne. Our final speaker today is James Cocaine. James is the Principal Policy Officer for Research Ethics and Governance Unit at New South Wales Health and Medical Research. James, thank you very much for your time today as well. We look forward to hearing from you.
Lovely, Shani. Thanks very much, and also recognise the land that we're all meeting on today, and the traditional owners of those, and acknowledge elders past, present, and emerging. I think the field has been covered very well by the previous two speakers, so I won't take up too much of people's time, but I'll probably draw out a few aspects from the slides that we've got there. The next one, I think I'm just going to look at the current situation that we are in New South Wales, some of the planned activities we've got, but also looking, and I think Kylie's sort of heralded it a bit in her presentation, but looking about the pivot, how we're going to move beyond this. And just last one might be some points for discussion, but some issues that we're looking at. So on the next slide, and I know Tam's pointed it out that there's certainly lots of guidance out there, the Commonwealth and the New South Wales guidance, but also I noticed that Queensland has put out some guidance too, and lots of sponsors. It's almost a viral outbreak of guidance that's coming down on everyone. The situation, really, I think the guidance we've had and have put out has been really in anticipation of what might come. And so while we have the guidance, it's been reasonably consistent with everyone else, has been to say that we really need to plan for almost a tsunami that was coming. And I think we've probably had the massive spike of amendments and things like that have needed to change because of COVID-related activities, so social distancing and the like. But I guess the question for us is will it continue? And what's the the burden going to be on ethics committees and governance officers from now on? We've actually got newer guidance that's coming out later in the week. It's really just reorganising it probably into more of a logical way. But who knows? It might even be the last guidance depending on how we go. I suppose just as a summary on it, we've tried to have more to pivot towards more protocol deviations that have been batch reported rather than having an amendments where possible. Remember though, the situation on the ground, I think, and this is important for industry to understand at public health sites, that they are still, I think, dealing with and have been and still are dealing with a public health emergency crisis. Many of those people who are the clinical workforce have been diverted onto testing and tracing. Many clinics have been shut down due to social distancing requirements, and so that means, of course, no access to recruits. And of course, even in the day-to-day things like patients and participants aren't quite as sophisticated with Zoom meetings and others as those in health professionals, and so even routine visits can become a bit difficult. I think what we might like to think about though is just how research has been seen. Some areas, but certainly not all areas, where research seems to have been seen as this sort of non-essential or even a drain on hospital resources that those things might be needed if the crisis reaches a peak. And so I think we need to have an understanding of whether that is really it's important that has been seen, but we can't sort of flip the switch all the way to the end. We need to have a more nuanced understanding of it. On the next slide, I talk a bit about, if we can go to the next slide, just about the guidance. But as I say, I think it's pretty much been covered by most, by certainly Tam and Kylie. It's not something that we've departed very greatly from on others, but I think it's all about working out. You need the consent for participants if you're changing their activities massively, but also to say suspending and terminating studies. We've been very clear in the guidance too. It's a very big consideration, even in the current climate. We want as little research waste as possible, including the ethical issue of participants who've, of course, put themselves at risk for study data to be collected. If you're suspending or if you're terminating that study, then at least there must be some consideration into how the study can practically achieve an outcome even after the COVID situation has passed. So on to the next slide. Looking at in New South Wales particularly, I think it's going to be important for us to capture some of the COVID-19 data. We're configuring our system and amending some forms to capture that in our Regis system. Really, we want to get as specific as possible with as little burden as possible on investigators and research officers. So it's a sort of a checkbox thing, but I think it's going to be important for us to understand how after COVID has passed, what putting the blocks back together, and so that's to understand where the impact has been and what's happened. So on the next slide, I'm talking about some planned activities in New South Wales. We're looking at, now that we're in a position of fast-tracking COVID-19 trials, we're able, obviously, there are still trials that are really important for people who have got life-threatening diseases, and so lots of cancer trials, for example, which can't just stop, and they also need to be fast-tracked too. But we want to triage how those trials should work within the startup process. We would note, of course, there's a framework that we're putting together to accompany the guidance, which is put out later this week. Many of the ethics committees in New South Wales are already agile. Almost all are conducting their meetings through Zoom or like platforms. And in fact, many have experienced some very beneficial outcomes from that. People are sharing members where possible. And I know Kylie's, of course, mentioned looking at it would be an opportunity for looking at how an easier way to conduct meetings through remote teleconferencing, but even to be able to have investigators present at meetings to discuss issues in real time is something that ethics committees can look towards. I think also as public health organisations, we should look to what successful models. So Bellbury's a good example of this, and just work out how to obtain and keep expertise, including remuneration. This isn't just a COVID activity, but I think a crisis brings out, some of the issues that are sort of long-standing there. Governance is another part, and we're working through this with the sector, and we'll release how we're going to do that too. But that's, it's all part of fast-tracking some of those COVID-19 activities. I'll move on to the next slide, and just to say that I think what we as a sector now need to start to do, institutions, CROs, sponsors, and I totally agree with the points that Kylie made. We need to start planning now for getting back to a business as usual for research activity to resume. I know social distancing will probably be with us for a while, and we'll need to work around that. But I note schools look to be going back in week 3, partly, possibly. So we seem to be getting on top of this pandemic much quicker than we anticipated. And I know you can't see me, but I've got my fingers crossed behind my back while I'm saying that. But it's very important. I think we've got the opportunity now. The US, UK, Europe, I think they could be dealing with this for a long time to come. I think in terms of research governance and with a big G, while the activity is possibly a bit lower, I think we need to move towards opening up those trials where they can continue. Obviously, the most important thing we need is a vaccine. It's still required. And I think it's time for all of us in research to sell the message that research, as it was put to me the other day, isn't a liability or a hobby. It's actually what will help us get out of this mess. And so I think that's part of all of our roles to do that wherever we can. Finally, just a couple of issues to assist on the next slide is. We're looking to see how the one more slide is to see how the sector can help. I think really with your studies, liaise with your ethics committees and your RGOs early in the pathway. I think it's really important for that. And many are doing that, and I think it's a way that we can help us to process things as quickly as possible. And finally, just on e-signatures, it seems to come up a bit. I think this is probably somewhere where ARCs can help us. It's certainly I think it's probably more about the platform than anything else. People are looking to different ones like DocuSign and the like. Some sponsor companies are well, let's take from sites. Firstly, some sites are very happy to do that, others not. But I think most are very keen to do e-signatures, but some sponsors are, some sponsors aren't. I think if ARCs maybe can help us find a platform that's acceptable for all sponsors, then from the OHMR's perspective, we can assist with recommending a platform to the sector just to facilitate those. So, noting that's probably time, so I'll let Joe and Shani take us through some questions.
Can you hear me? I think Shani must be having a problem.
Sorry, yes, I'm just having more problems, but I was just saying, and I'll say thank you very much, James. I think the topics that you covered there as well were really important, as were all the speakers today. Thank you very much for those. We'll go into questions now, and I do thank Joe for filling in for me as I've multiply dropped out. But just one thing I do want to say that, and I've spoken to a number of people at sites and particularly around the HREC issues and what they can do and what they can't. And I keep saying to them, if the patient is safe, if the staff members are safe and the data is maintained in integrity, then if you can do those things, then you're pretty well going to be okay. We must keep trials going where it is all those things, safe for patients, safe for the staff, and keeping the data going for the patients that have gone before us. I agree. So that's really important to consider, and as James says, to keep the plan, start that planning to get us back on track for the future. So let's go to Sue Mason, who's going to be triaging the questions. Sue, I'll hand it over to you.
Thanks, Shani. Some of the questions are aimed at all the speakers. So what I might do is just ask the question and then ask Kylie to respond first, and then give Tam and then James an opportunity to respond in addition if they want to. So the first question is, so far we've seen a great deal of flexibility, adaptability and responsiveness. How much of this do we think will last after the COVID-19 crisis passes? i.e. will online and PRN ATRIC meetings now become the norm? So Kylie, what are your thoughts?
Thanks for that. I'm kind of chuckling because I think all over the country, actually, there's lots of similar conversations. We certainly, all sorts of sectors have had a rapid education in things like teleconferencing and video conferencing and working remotely. And I think I would hope that there are going to be aspects of kind of learning that we actually would want to continue with. Certainly, I mean, in our own organisation, we've gone to fully remote meetings as well as a fully remote operational team. And if I think about the HREC meetings, for example, I mean, we had long used technology to facilitate remote attendance at meetings, but we'd always maintained a physical meeting at the heart. And we've actually had some really interesting feedback from remote committee members about the balance of a fully remote meeting versus a meeting where only a couple of attendees might be remote. So certainly ourselves, we did what was necessary to provide continuity of service through the pandemic. But in doing so, there are of course aspects of what we've done that we will reflect on and find beneficial and probably won't rewind altogether. And I would imagine the same would be true, across all sorts of sectors and all sorts of places and in clinical practice too. Things like e-signatures, there are lots of sites to whom that will not be new news, that will, have been using those soft technologies for a long time. But again, this might be an opportunity for others to have seen what works. Equally, as we try, as we've provided continuity through this time, there'll be other things that really reinforce to us that there's good reasons for old practice, and we will go back to those. But I would think we all probably want to make the most of this opportunity to actually try some new things and understand what provides benefits that we should be including in as we go forward. In terms of things like flexibility, I mean, certainly I would hope that that's what Bellberry provided, and I know that's what a number of other service providers would have hoped for as well. And indeed, let's try and back that in through this process. As James said, this is an opportunity to it is an opportunity to reflect on some of our practices and take what has provided benefit.
Thanks, Kylie. Tam, do you have anything that you would like to add?
No, I mean, it's again, really taking the learning from this experience and how we can actually better service, all of the stakeholders. And I think to Shani's points, it's about making sure the sector we, sort of really can improve on our efficiency and really driving, sort of KPIs and continue to promote, Australia as a place to do clinical trials. And that's part of that is through ethics and governance.
Thanks, Tam. James, do you have anything that you would like to add?
I look only quickly to say that you know, fully remote meetings. Western New South Wales Ethics Committee have been doing it for years. I think now everyone's just sort of catching on, and they're going, "Wow, this is actually really useful." And I note at our roundtable a couple of weeks ago now with ethics and governance officers, many people said it actually changes the dynamics of the meeting. You get people who who feel like they're contributing far better than they perhaps were before. So I think you'll find that it won't, that aspect certainly won't die away. I think it'll be that'll be a business as usual, I think, from now on.
Thanks, James. The next couple of questions were actually posted while you were speaking, Tam, so I'll direct these to you. What types of protocol amendments are expected, and what changes should be currently made to a protocol? And what if the international sponsor doesn't want to amend the protocol as relevant for COVID-19?
So, some of the protocol, I mean, obviously relating to the COVID-19, and more on the logistics side. So I can sort of pinpoint. I mean, if the person can sort of direct a bit more in terms of the scenario, but typically we would work with the sponsors or the CRO and go through whether the protocol is required, the protocol amendment is required, and again back to that first principle, the safety of our trial participant and staff is the priority of all the actions and decisions that we made. So it's pretty hard to pinpoint one particular amendment. And what was the second part of the question, Sue?
Just saying that if there was an amendment, what would be currently expected? Then what if the international sponsor doesn't want to amend the protocol as relevant for COVID-19?
Well, that's something between the, I guess, the sponsor CRO need to deal with the international sponsors or headquarter, and there's all that guidelines, within Australia that I guess, trials sponsors and CRO need to abide by.
Thanks, Tam. The next couple of questions I'll aim at you, Kylie. Is there any guidance regarding the HREC approach to remote consenting? That's the initial consenting of participants when the patient is unwilling or unable to attend the clinic. And have you received many of those requests?
Sure, and I might actually just touch on the previous question as well, just really building on what Tam said. I think, each of these kind of questions and considerations is going to be taken on a study-by-study, case-by-case basis. So it's always going to be, we'll be able to talk in generalizations, but it's always going to be worth saying you should speak to your local HREC. I think we're all saying very similar things, which is, around the fact that we'll work with you to make this work through this period. We all recognize we're not in a normal period. We're all, hoping to come out of this to, a more normal situation as quickly as we can, but we recognize we're not in normal at the moment. So in terms of, how changes can be documented, in some cases we've actually seen, other mechanisms used over and above a full change to a protocol. We'd have some sympathies with, sponsors may be in a situation where a protocol running across multiple jurisdictions, for example, it's very hard to change that for every jurisdiction. As we've said, the situation in Australia at the moment is very different to that in the US and the UK and Spain and so on. So in some cases, we're certainly recording that in ways other than a full protocol change. So it might be in a protocol amendment or in a file note or in another kind of report. But we're working very much on a case-by-case basis with studies and sites about that. And then in terms of what the content might be, certainly we have had lots of discussions with various different sites about moving to remote processes. So whether that's undertaking screening remotely, pre-recruitment screening, whether that's actually undertaking some monitoring remotely where that might be possible, site visits, for example. Or even, thinking about relocating. So, as we've said, not all participants, it's important to, I think, meet the participant where they are. So there'll be some participants that are very comfortable with moving on to remote and are reluctant to come into clinic. Equally, there'll be others who are keen to continue coming into clinic, and there may be others that might be open to having, maintaining a physical interaction, but thinking about where that interaction takes place. I think it's important to remember in all of these cases, what we're saying is, really think about your particular study at your particular site and what makes sense for you, and then work with your local ethics committee. I think you will find us all supportive about making that work for the participants, the site, and the continuity of the study where that's appropriate.
Thanks, Carly. There is another question here that says, we see that most of the new and upcoming global trials and non-COVID-19 trials are paused. What is the opportunities and possibilities for these upcoming trials looking like, and how and when should sponsors start initiating activities on these future trials? So I'll hand it over to you first, Kylie.
Yep. Yes, I'm really happy to respond to that. And I think, as both Tam and James have said, we've obviously spent the last couple of months putting plans in place, contingency plans for the worst case scenario. And as we've all said, fingers crossed, we look to be in a much better situation earlier than we might have hoped. And we are now planning for, what comes after. Recognizing that we may well be in this period of changed normality for a little while yet in order to get us to what comes after. But I would really agree with what James said. There is actually, without sounding too cynical about it, there is actually a bit of an opportunity at the moment for Australian sites compared to other jurisdictions around the world. Now, the policies that sponsors have put in place, just like the policies that regulators have put in place, have been developed over the last number of weeks as we have all been planning for the worst. So, it's probably worthwhile watching this space. I can't speak for sponsors, but I would have imagined that over the next few weeks and months, they will start looking at what the future of their research programs looks like, and I would imagine in that they will be looking at, where they've got halts on recruitment, is that still the appropriate decision, and does that change on a place by place basis, and of course for new studies too. I mean, even for new studies coming in the future, of course, we've actually seen a number of sites that are using this time, this kind of quieter time, to get ready for studies that they intend to start in the future. So just if recruitment is halted at the moment, of course, that doesn't prevent people from putting their initiation plans in place and getting ready for what comes after. I hope I've answered the question, Sue. I'm not quite sure.
Thanks, Kylie. Just Tam, would you like to add anything to Kylie's response?
Oh, no. I mean, I think we're all on the same page, and I think, it just really, it's the case of waiting for the rain to be over and run out to the sunshine. So we've certainly seen, studies coming through with that view, and I guess, it's something that I think the sector as the whole, and this is something that, MTP Connect and a few other groups, wanting to continue to maintain our, that competitiveness in the medtech biotech sector. So yeah.
Okay, thanks, Tam. And James, would you like to add anything to Kylie and Tam's response?
Look, nothing very sensible. I know we're very close to time, but I think the true answer to the question involves a little bit of crystal ball gazing, and I think Kylie's probably done as best she can on that too. The situation will continue to rapidly evolve, and so when people when sponsors are starting to plan for non-COVID related studies to start back up again, I guess it's to say, well, what's the environment look like? How are you going to recruit? Are you going to have, is there still going to be social distancing there? How are you going to manage all of that? So I think, it's hard. Each trial will be different, but I think certainly liaise with your research office and your ethics and governance people early, and start doing the planning now while we're a little bit quieter. Thanks.
Thanks, James. Shani, I'll hand it back over to you now just to
wrap it up.
Finalise.
Great.
Yes, and we'll take the other questions offline and we'll get those responded to. Thanks, Shani.
Yeah, great. Thanks, Sue. And again, thanks to our speakers, Kylie, Tam and James, for their contribution today. And also thanks very much to our sponsors, MCP Connect, working as a growth centre across the sector, and New South Wales Health, who probably getting the brunt of COVID-19 with the most cases here. Look, it's been a great session. Again, this is recorded, so we will provide that recording on our website for those who couldn't make it, and for you to refer back to it. And we also collect the questions and do a Q&A on those afterwards. Next slide talks to our next session, where we'll hear from clinical trial sponsors and CROs, just to get a perspective from them and what they're seeing, both in Australia and internationally. And I look forward to that next week on the 28th of April. Thank you very much for your attention, and have a great, safe and distanced time. See you next week.